How did you enter into shoulder specialty?
To go to London, so where I did my fellowship in shoulder surgery for almost 2.5, 3 years in King's College Hospital.
Retaining their shoulder movements and the stability.
That's a very important question. Prevention is better than cure.
Yeah. Waiting on the problem for too long.
I know, a stitch in time saves 9.
Yeah. That's a good one. Hello all. Welcome to AAG Orthopod podcast series. Today I'm with our senior shoulder surgeon, Dr. Harshad Jawalkar. We are going to discuss about the subspecialty practice in orthopedics. Myself, Dr. Srinivas Thati, HOD and Director, Department of Orthopedics and Sports Medicine at AAG Hospitals. We strive to give a focused subspecialty practice at AAG Hospitals because that makes a big difference in the results of conditions we treat. So, I'm going to discuss with our shoulder surgeon regarding how his practice makes a difference. So, welcome Harshad to the podcast series. Please tell me, how did you enter into shoulder specialty?
First of all, thank you so much for having me here. It's an honor. It's always a pleasure working with you in orthopedics. So, I trained to be an orthopedic surgeon.
Yeah.
So, as a general orthopedic surgeon, I treated the variety of general orthopedic conditions, fractures, hips, knees, and everything. But after a while, after about 5 years after I finished my training, I realized that shoulder is a unique and a challenging area. There are so many things that could go wrong with the shoulder. It needs mobility, it needs stability. There are so many things that could go wrong. And still we were in the beginning stages of understanding what the shoulder was all about. So there were a lot of lacunae in our understanding of the shoulders, a lot of lacunae in the training, identification of problems, how to treat them. And that is where it clicked that I had to subspecialize, and the shoulder was just ripe for my taking. So I got this wonderful opportunity by God's grace to go to London. So where I did my fellowship in shoulder surgery for almost 2.5, 3 years in King's College Hospital. I was fortunate enough to train with some of the best surgeons in the world, not only in surgical areas, but also in identifying the problems, treating them properly, giving better outcomes, cutting edge of research, cutting edge of surgical skills. And that's where it clicked. So that's how I got into shoulder surgery.
Yes, certainly I think that's what is the importance of having a subspecialty training, right? Like for us as a hip and knee surgeon, I know the breadth of the subject in orthopedics has total. I can treat the trauma problems, I can treat the sports injuries, I can treat the degenerative problems. Just like that, every joint has a particular set of problems. Like shoulder, if you look at the continuum, you can have simple issues like a nagging pain in the shoulder, as in patients having diabetes going into a frozen shoulder, or you can have sports injuries which can make the shoulder unstable, or you can have in the elderly like muscle tears like rotator cuff tears or arthritis in the shoulder. There's a big continuum of series. One of the reasons is the shoulder is a very complex joint, and unfortunately its mobility makes it prone to the injuries. So some patients come back with a really stiff issues, and some patients come with a very unstable shoulder. How do you analyze them, and how do you identify the right treatments?
Right. So that's one of the areas where specialization comes into play.
Mm-hmm.
So each joint has its own, how do I put it? It has its own language.
Mm-hmm.
It has its own set of presentation.
Right.
There are patterns in the way the patients present. So, like you said, it is a complex joint and there are lots of things that could go wrong. So it all depends. So the final goal is the outcome. So regardless of whatever the problem is, we have to give back the patient's world back to him. So whatever the patient wants, whatever his activities are, whatever his disabilities are, whether it's an athlete who's playing for the country or is going pro, wants a different set of requirements versus somebody who's retired and who's not very sporty. They just want to do basic activities of daily living. So it depends on what the patient wants, and then it comes to the shoulder.
Right.
There, the language of the shoulder comes into play, whether it is impingement, whether it is frozen shoulder, whether it is a rotator cuff tear. The ultimate goal is to reduce the pain, get back the mobility, and give back the functionality. So basically, with these things in mind, we go about clinically examining the shoulder, the patient finding whether there is stiffness, whether there is weakness, whether there is instability, whether there is arthritis. And then once we know what the patient wants and what the diagnosis from the shoulder is, then we tailor it accordingly.
Mm-hmm.
So most of the times, if I get to identify the problem early, if I get to see the patient early, then I can give back the function relatively easily with non-surgical means. With physiotherapy, I can do the job. But if they come to me late, then things might be a bit more damaged. So that time I have to shift my focus to surgical side, followed by physiotherapy. So it all depends on what the patient wants, really.
Absolutely right. So, yeah, certain shoulder conditions can certainly be treated without surgery, and some of them definitely need some intervention because that's what determines the results of the whatever treatment we have done. When we think about subspecialty practice again, why should a patient choose you than a general orthopod? What do you bring onto the table to the patient which would make a difference?
Well, that's a great question. So when somebody's doing the same thing again and again, day in and day out, when somebody is doing the same thing, then not only does the skill set improve, practice makes perfect, they say. Not only does the surgical skill set improves, but along with that, simultaneously, I mean, it might be subconsciously happening without even me noticing it, but the specialists can make out patterns in the way the patients are presenting. Even subtle complaints, subtle signs, they can give me clues to what is going on. So I think that is where the difference between a specialist and a generalist comes in. So for example, I see 20 patients having shoulder problems per day, and then it's easy for me to identify a subset of patients who will get better with a certain modality.
Not only that, the early signs you should be able to pick up quite early, right?
Absolutely.
Compared to somebody who is not seeing the same joint day in and day out. So your chance of picking up the problem, identifying the problem early, makes a big difference.
Absolutely. The earlier we pick them up, the better the outcomes are, the happier the patients are.
See, as a general orthopod, I'm specialized in the different areas. I do see a lot of patients with shoulder problems. But the observation is a lot of patients will not go and see a shoulder specialist per se. They'll come to somebody they know, they trust, and I think there is certain kind of hesitance of the patients to consider that is as a problem. Most of them, what I see is they live with that problem. They come with another problem and they'll add on that, oh, I have a niggle in the shoulder, this is troubling me sometimes, I can't sleep, but I'm not ready to go for any consult to get this treated. So I do see that as a general thing in common population, saying that as an aging process. But I don't think that is just an aging process. There may be something going on which the patient has to consult and find the specialist. So what is your perspective on that?
Absolutely, you're absolutely right. So first of all, let me state that orthopods in general orthopedic surgeons, I'm not competing with them. Okay, it's not a competition. It's all
Absolutely.
it's a teamwork. It's all, for example, the way we work, it's a teamwork. So general orthopedic surgeons are like maybe the frontliners. They identify the problem and the basics they are able to do. That is the first thing I want to say. The second thing is, like you aptly mentioned, people attribute any issues with the shoulder, any niggling issues or otherwise. They might say it is because of some strain, because of some age, and the tolerance for this sort of pain is pretty high. It's easy for somebody to sort of internalize the injury and say that, yeah, I'm going to adjust my lifestyle. I'm okay with living with this pain, living with not able to lift my shoulder. But it is not the right thing to do. Over the last few years, specialists like me have come into play, and our facilities we are available to the common people in India, unlike in the West, where they have to wait for weeks, if not months, to get a specialist appointment. So when they come to me early, I can fix them. It's not about ordering high-end investigations. It is not about interventions, but it is about identifying the problem when it is still a small, treatable thing. So once I am able to pick up the diagnosis, the treatment becomes easy, and it changes the trajectory of the patient's life.
Right.
So it's these minor problems, instead of becoming sort of I will accept them and lifelong disabilities kind of thing, it's easy to get back the shoulder function. If we treat them early, it might be something as simple as getting a few blood tests done and starting physiotherapy. So coming to a specialist early means better outcomes, quicker outcomes with simple measures, instead of making the problems bigger and complex and thinking about surgery. It makes sense to sort of nip the problem in the bud.
Absolutely, I think the prevention is better than cure. Right?
Absolutely.
So we had to follow that. Definitely not.
A stitch-
Not waiting on the problem for too long.
I know, a stitch in time saves 9.
Yeah, that's a good one. So, coming to the specific issues with the shoulder, okay, we see instabilities mainly in the young population. And I do see a lot of patients coming with the patellar dislocations because of the ligament laxity and all that. So there's a kind of a decision-making process in how you treat these patients who have instabilities. So what are the criteria you use and how we are going to tailor your treatment plan to them?
That's a very important question. It's an ongoing controversy in even orthopedic conferences and shoulder specialists. But the general guidelines are pretty clear. I mean, this is what I implement in my routine practice also. So there is a subset of patients in which there is ligament laxity. That means generalized ligament laxity. That means they are hypermobile. They might be associated with syndromes, maybe not. Just for lay people, they might have seen people contortionists who sort of bring their head between their thighs, who squeeze into small suitcases and boxes. These are the people who are more prone to sports injuries, especially if they do something which is especially hard on the joints, like active sports, overhead sports. So these people with ligament laxity, due to repeated overuse, they tend to have a certain amount of problems with the shoulders, including a propensity for dislocation, not only the shoulders but also the kneecaps, a lot of things. So these people, they need a careful analysis. If there is a structural damage, if there is something torn, if they have a proper sports injury like a labral tear, a Bankhart's lesion or a Hill-Sachs lesion, then there is a significant chance, there is a significant role of surgery along with physiotherapy.
Right.
But if there is no structural damage, then they should not be operated upon. The results will be poor with surgery. But on the other end of the extreme, there are people who don't have ligament laxity, who had injuries to their shoulder. Maybe they fell down, maybe they were in accidents, and then the shoulder dislocated and then went back in. So these are normal shoulders who have injured themselves, who have sports injuries which make them unstable. So these people, they definitely need surgery. And along with these two subsets of patients, the age of the patient also makes a big difference. The younger they are, the more chances of repeated dislocations there are. The elderly they are, then the chances of dislocation comes down. There's a separate subset of elderly patients who keep having repeated dislocations. So they have rotator cuff tears associated with them. So we have to sort of identify what we are dealing with.
I think that's where the subspecial role comes in, right? So understanding of that deeper knowledge, like knowing the minute details on how a smaller intervention makes a difference in the results in the long run. That's the most important aspect. The middle age and the elderly, as we go into elderly age, what we see is common impingement and then adhesive capsulitis. I think these are the two common problems. People get confused. I see a lot of our colleagues, general orthopods, writing down kind of a different kind of diagnosis, but when you actually look at it can be falling into any of these two categories. So how do you treat them, and what happens if they don't get the treatment in the right time?
Again, the treatment boils down to pattern recognition. So it's easy to identify whether it is capsulitis or impingement if you know what you're looking for. So that makes the specialist slightly at a better place position to identify the problem.
I won't say slightly, largely.
I wanted to,
be modest.
Modest about it, correct.
Right.
So the treatment, even if I say physiotherapy for these two conditions, which is the initial treatment, the exact modalities of what to do, the exact technique of the physiotherapy will be significantly different for a patient who has impingement versus somebody who has capsulitis. We will be focusing more on increasing the gap for the muscle in impingement. That means we are working more on the scapula, the shoulder blade, the strength, the posture, the alignment of the spine, all those things in impingement. But when it comes to capsulitis, it is more about managing the pain first, then movements, mobilizing the shoulder, and then the last will be the strengthening part, the posture, the scapula. So identifying them makes a difference in the early stages also. And it's easy to get confused because what might work for a frozen shoulder might not work for impingement, and the results will be bad. The patients will not be happy. They'll say, the doctor, we took this, we took that, we got an injection also, we tried physiotherapy, but it didn't work. But the problem lies in the diagnosis, not with all these techniques.
True, that's right. If you don't get the diagnosis right, whatever you do, how many PRP injections you do, it is not going to help. So that's where the training is very important. So yes, PRP is one of the other things, right? We have seen so much of usage. Is there any role in any of these shoulder conditions?
To be brutally honest, no. I might be stepping on a few toes here, but evidence, literature, and even maybe a little bit of experience also says that PRP does not work in the shoulders. I'll sort of give a small caveat with that. It works in certain conditions of the elbow. It works well for tennis elbows. Maybe it works well for Achilles tendon problems. But in the shoulder, there is very, very...
Even for the elbow or the Achilles, that is only anecdotal research papers which have shown that. But if you look at the long-term RCTs done, even there it is not of any use. So... let's not get into that. Let's go back to the actual shoulder practice. The other common problem in the elderly particularly is cuff tears.
Yeah.
And when I see a patient with a cuff tear, when I suggest surgery to them, a lot of them will be taken back. They won't be much interested, and many of our colleagues also will say, no, you don't need surgery, kind of a thing. Does surgery make any impact on the results and function of the patients who have rotator cuff?
Absolutely. The answer is a definite 100% unequivocally yes. for rotator cuff tears, in general, surgery has a big role. There will be exceptions to the rule, but in general, rotator cuff tears, we are talking about active people, we are talking about relatively young people who like to enjoy their life, who don't want to struggle with pain or weakness in the shoulder. So in general, up to the age of, I'd say 65, 70, especially if there has been an injury, then surgery definitely has a role. Because I know it sounds a little counterintuitive. The body generally tries to heal all its injuries on its own. But this is one of the few rare exceptions where the body cannot repair the rotator cuff tear, because it always keeps getting pulled from the muscle on one side, and the tear can't heal. It cannot go back onto the bone and heal itself. So most of the times surgery is helpful. It'll help give back the patient his
correct. I mean, I keep telling my patients when they come and see me with a rotator cuff tear, see, the muscle tends to push the ball into the cuff like that, and it will move in that direction, right? So there is no glide or friction in the joint. If you leave a shoulder with a rotator cuff tear, the glide or the friction which it causes takes it into arthritis.
Correct.
That's what we call as cuff tear arthropathy.
Correct.
And certainly now the treatment for cuff tear arthropathy will be a replacement. So if you have fixed the tone cuff back onto the shoulder, you're going to get the movement back. It may take around 3 months for you to recover from the surgery, but mind you, this is all minimal invasive, right?
Absolutely.
You guys are very lucky in shoulder, because most of the surgeries you can do through a keyhole.
Absolutely.
Right? Minimal invasive surgeries. And I think that's where the expertise comes in place. If you think about a general orthopod, I don't think it's that easy for them to do a arthroscopy in the shoulder, because they can get lost in the joint, even though it's a tiny joint. But as a specialist, I think you can fix that better. So cuff tears can be treated with minimally invasive surgery like arthroscopy. If they're done early on, your risk of developing arthritis is very less. But once the patient ignores that, goes into cuff tear arthropathy or arthritis, then you need to do a reversal. I remember one of your patient who was I think 75 or 80-year-old, who came with a really bad cuff tear, left for a long time. And I think, how did you convince him? Because when I spoke to him about the reverse shoulder, he was in a shock. And I said, you are the best to go to. And luckily he turned up to you.
Correct.
And how did you convince him to get the surgery done? And how happy is he now?
Oh yeah, I think this was about a year and a half ago.
Yeah.
So this guy was a senior sitar player.
Okay.
So he's one of the rare people in the country who can play the sitar holding it vertically.
Right.
So to continue playing the sitar, he needed to be able to do this. He needed to get his arm above the shoulder and then play the sitar. Because of his cuff tear, he had pseudoparalysis. He couldn't lift his hand above the shoulder level. So he was trying to play it horizontally, the usual way, but not vertically. So he was like, he was desperate. He was saying, can I ever get my hand above the shoulder level? Can I play the sitar vertically, or do I have to give it up? Because it's a rare art and he wants to teach his students. So I said, yeah, I mean, there is damage. You've ignored this injury for so many years. The cuff tear was there, now it's become arthritis, and then your shoulder doesn't have the power to move itself. So then we went through a few discussions, a few consultations. I convinced him, not only him, but his wife also. They were both pretty skeptical about having such a major surgery at that age.
Correct.
But we went through, did a reverse shoulder replacement. By God's grace, it went really well. He was a very compliant patient. He was really focused. He was also engaged with the treatment. He followed all the precautions. He did physiotherapy. And he came back to me almost a year and a half later. Now he's back to his passion. He's gone back to playing the sitar, and he's He recently had a concert in which he's able to do this also. So it depends a lot, not only on the injury but also the patient's psyche, how keen he is to deal with the problem.
See, every patient is not the same. Everyone's requirements are not the same. But I think as we are seeing that our lifespan is increasing, we need more independence as we are aging. So if anybody has any nagging issue in the shoulders, I don't think they should just sit and think that is age, because the things which we can do to make their life more better. So it doesn't mean that surgery every time, but even with the surgery, I think there's nothing to worry about, because we are in such a fine kind of a world now. We can do a lot of things very safely. Okay, so don't have to worry. And as a shoulder surgeon, at the end of whatever treatments you're doing, what kind of goals you give to the patients? How do they maintain the shoulder health?
So they have to participate in the physiotherapy protocols that I suggest. So after surgery, there will be a brief period of rest. They have to follow that. Then the physiotherapist will be actively participating in the surgery. It will be supervised physiotherapy. Once that is done, after a few months, after about 3 to 4 months, once they get back their mobility, once they get back to their routine life, even after that, they have to make sure that they retain their function. So I advise an active lifestyle. I advise them that they keep their shoulders strengthened and conditioned with some regular exercises on a daily basis, and they should enjoy life, basically.
So at the end of this podcast, one final question: what do you suggest in general, all the population, either young or middle-aged or elderly, how should they go about retaining their shoulder movements and the stability?
That's a very important question. Prevention is better than cure.
Yeah.
So take care of your health. So whatever are the general rules of healthy lifestyle you follow, but specifically make sure your shoulders are strengthened and conditioned. If it is, if there's somebody who's elderly, who's not keen on going to the gym and doing something, there are a few general guidelines. Number one, they should practice 5 minutes of some regular mobility exercises, some regular strengthening exercises. There are lots of resources available online as well. There's a lot of overlap between yoga, Pilates, physiotherapy, gym trainers. There's a lot of overlap. But something as simple as doing shoulder rolls, shoulder shrugs, maybe push-ups, if not full horizontal push-ups, maybe wall push-ups. So these sort of general mobility and strengthening exercises have to be incorporated as a daily habit. So every day, just 3-4 minutes is enough. Get some of these exercises to maintain your shoulder mobility. The second important point, which is absolutely crucial in modern times with the lifestyles that we have, most of us have desk jobs, not enough time for sunlight, exercise. So you have to maintain a proper posture. Posture is critical. So you have to have the right posture that will prevent a lot of problems, not only with the shoulders, but with the body in general, the spine, the neck, the hips, the knees. A lot of things can be avoided by proper posture. Another third important point is to listen to what your body says. So you have to be tuned in to how much your body can do and what it can't do. Right. So these are the 3 general guidelines which I'd like to finish
Absolutely.
off the podcast
So
with.
in a nutshell, 3 important things are: maintain good muscle strength, maintain the mobility of the shoulder, maintain the posture, and don't sit on a problem for long.
Correct.
Get it fixed early. Great. Thank you. Thank you very much, Harshad.
Pleasure.